What if the most dangerous thing about a surgery is not the condition that sent you to the operating table, but the surgery itself? What if the recommendation your doctor just gave you, delivered with complete confidence, backed by years of training and genuine good intention, is actually the wrong choice for your specific body at your specific age? I know that is a difficult thing to hear. We are taught from childhood to trust doctors completely, to sign the forms, to follow the plan. But after 15 years of clinical practice, I have learned something that I believe every adult over 60 deserves to know before they ever find themselves sitting across from a surgeon. A surgical recommendation is not a verdict. It is the beginning of a conversation. And today I want to make sure you are equipped to have that conversation fully and confidently. I am Dr. Weston, and today we are going to talk about 5 surgeries that carry serious hidden risks for people over 60 that most patients are never clearly told about before they consent. I am not here to frighten you away from surgery. Surgery saves lives every single day, and I have seen that firsthand. What I am here to do is give you the complete picture, the questions to ask, the alternatives that exist, and the information that allows you to be an active participant in your own care rather than a passive recipient of someone else's decision. Before we go any further, I want you to drop a comment below right now and tell me, have you ever been told that surgery was your only option for a health problem? Just yes or no. And if you or someone you love has ever experienced unexpected complications after an operation, please add the word complications to your comment. I read every single comment personally, and today your answer is genuinely important to the conversation we are about to have. Now let me start with something that most people have never heard explained clearly, and that changes everything about how you understand surgical risk after 60. When a younger body goes through major surgery, it has significant reserve capacity. Its heart can compensate for the extra demands of operating. Its lungs clear anesthetic efficiently. Its kidneys process medications quickly. Its brain returns to normal orientation rapidly. But after 60 and increasingly after 70 and 75, something important has changed. Not just age itself, but what doctors call frailty. Frailty is not a casual word. It is a specific medical term that describes a condition where the body's reserve capacity has fallen below a critical threshold. Some research suggests that a significant proportion of adults over 75 show measurable signs of frailty. And a frail body faces surgery very differently than a robust one. Here is the distinction that matters most, and that most surgical conversations do not address clearly enough. The question is not whether your body can survive the operation. Most bodies can. The real question is whether your body can survive the recovery. Those are 2 entirely different challenges. And the answer to the second question depends on factors that go far beyond the skill of the surgeon or the quality of the hospital. It depends on the total reserve capacity of your kidneys, your heart, your lungs, your immune system, and your brain. All of them simultaneously, all of them under stress at the same time for days and weeks after the procedure ends. I have a patient I want to tell you about, a kind and fiercely independent 74-year-old woman named Eleanor, who came to see me after being told by 2 different specialists that she needed open heart surgery for a blocked artery. Eleanor was not afraid of the surgery itself. What she was afraid of was what she had watched happen to her closest friend the previous year. Her friend had gone into a routine cardiac procedure at 72 and come out of it confused, exhausted, and in Eleanor's words, simply not herself anymore for months afterward. Eleanor sat across from me and said something I have never forgotten. She told me she would rather have fewer years being herself than more years being someone her family had to look after. That sentence stayed with me because it captured something that surgical consent forms almost never address: the quality of the life on the other side. When Eleanor and I went through her complete health picture together, her kidney function, her cardiovascular reserve, her cognitive baseline, her overall frailty score, what emerged was a picture that genuinely supported a different path than open heart surgery. A less invasive catheter-based approach existed that was appropriate for her specific situation. She did not need the full operation. She needed a doctor who took the time to look at the whole picture rather than just the blocked artery. Eleanor took that less invasive path. 18 months later, She told me she was back to her garden and her weekly walks and felt more like herself than she had in years. But wait, because what I am about to explain now is the piece of this conversation that most patients never hear, and it is the most important part of today. The first surgery worth understanding clearly is open heart surgery in older or frail patients. Coronary bypass surgery is one of the most commonly performed major operations in older adults. The principle is straightforward. Blocked arteries are bypassed with new routes for blood flow. For the right patient in the right condition, it can be genuinely life-changing. But here is what the standard surgical consultation often does not fully explain. Open heart surgery requires stopping the heart completely and placing the patient on a bypass machine that takes over the work of the heart and lungs during the procedure. For a 60-year-old in strong overall health, that is manageable. For a 78-year-old managing kidney disease, diabetes, and any degree of cognitive change, that bypass machine places simultaneous stress on every major organ in the body at once. Some research suggests that in frail older patients, open heart surgery may carry a meaningfully elevated risk of serious complications, including stroke, kidney injury, prolonged confusion, and extended time on breathing support. The critical question to ask your cardiologist or cardiac surgeon is this: am I a candidate for a catheter-based approach rather than open surgery? In many situations today, a minimally invasive procedure exists that achieves a comparable result without stopping the heart or opening the chest. That one question could genuinely change your outcome. Pro tip number 1, before any major cardiac procedure, ask specifically for a frailty assessment. This is a formal evaluation of your body's overall reserve capacity that some research suggests should be standard practice before recommending major surgery in older adults. Not all hospitals do this routinely. Asking for it ensures your full picture is being considered, not just the specific artery or valve that brought you to the appointment. The second surgery that carries hidden risks for older adults is aggressive spinal surgery. Back pain after 60 is extraordinarily common, and the solution that gets recommended with increasing frequency is spinal fusion, multi-level decompression, hardware placed along the spine. Now, some spinal surgeries are genuinely necessary and genuinely urgent. A spine actively compressing the spinal cord, causing loss of function or bowel and bladder control, requires surgical intervention. That is not what I am discussing here. What I am discussing is elective spinal fusion for chronic back pain in older adults, where the evidence deserves far more careful consideration than most patients receive. Some research has suggested that in older adults, complex spinal fusion carries a complication rate that is considerably higher than most patients are told at the outset. The most significant complications are not minor. Blood clots, infections, hardware failure, and a condition called adjacent segment disease, where the vertebrae above and below the fused section begin to deteriorate because the mechanics of the spine have been permanently altered. One part of the spine is made rigid, and the sections around it absorb consequences they were not designed for. Perhaps most importantly, some research has found that for many older adults with degenerative spine disease, aggressive fusion surgery may provide no meaningfully better long-term pain relief than a well-managed combination of physical therapy, targeted injections, and appropriate pain management. Same pain outcomes, but with dramatically higher procedural risk. If you have been told that spinal surgery is your only option for back pain, I genuinely encourage you to seek a second opinion from a spine specialist at a different institution before proceeding. Tell me in the comments right now, have you ever been told surgery was the only answer for back pain? I want to know how many people watching have heard those exact words, because your experience matters and it might encourage someone else to ask more questions before agreeing. The third surgery requiring careful consideration is major cancer surgery in older or frail patients. I want to approach this one with particular care because I understand the emotional weight that comes with a cancer diagnosis. When someone hears the word cancer, the instinct is immediate and powerful. Remove it. And I completely understand that instinct. But 2 decades of clinical practice has taught me something important. that I believe every older adult deserves to hear. The goal of cancer treatment is not simply to remove the tumor. The goal is to give the patient more good years of quality life. And sometimes, not always, but sometimes, major surgery in an older, frail patient may not achieve that goal in the way everyone hopes. Some complex cancer surgeries are among the most demanding procedures in all of medicine, requiring many hours of operating time and weeks of recovery even in healthy younger patients. In an older adult managing heart disease, reduced kidney function, and low physiological reserve, the surgery may technically succeed in removing the tumor while the patient's body is unable to recover from the operation itself. This is sometimes called futile surgery, and some research suggests it is more common than the medical community openly acknowledges. The question worth asking your oncologist directly is this: if we do not operate, what does a non-surgical approach look like for someone with my age and my specific health profile? That question opens a conversation that many patients never know to have. And sometimes the answer behind that question reveals an option that is genuinely better for that particular person at that particular stage of their life. Pro tip number 2: when facing a major cancer surgery recommendation at any age over 60, ask specifically about your performance status. This is a standardized medical assessment of how well your body is likely to tolerate major treatment. It is a formal tool that exists precisely for this purpose. Some research suggests it should be part of every major surgical oncology decision for older patients. If your care team has not mentioned it, ask about it directly. The 4th surgery is elective joint replacement in patients with multiple serious health conditions. Hip and knee replacements are genuinely among the most successful and quality of life improving surgeries ever developed. For the right patient, a new hip can be transformative. I say that without any reservation. But the word elective means planned. It means you have time. Time to think, time to prepare, and time to ask whether this is the right moment for your specific body right now. Because some research has suggested that in older adults managing multiple serious health conditions simultaneously, the risks around elective joint replacement are meaningfully higher than in healthier patients of the same age. Blood clots are the most serious concern. Clots forming in the leg veins after surgery can travel to the lungs and become life-threatening. In older adults with reduced circulation, this risk is higher than in younger patients. Post-operative pneumonia from reduced mobility during recovery is another real concern, as are hospital-acquired infections and the cumulative demands of anesthesia on already stressed organ systems. The question here is not whether to have the surgery. The question is whether your body is in the best possible condition right now to go through it and recover from it successfully. Some hospitals have introduced what is called a prehabilitation program before scheduling elective joint replacement for higher risk patients. This involves a structured period before the surgery of optimizing blood pressure, blood sugar, cardiovascular fitness, and nutritional status to reduce complication risk. Some research suggests this approach meaningfully improves outcomes. If your hospital has not mentioned prehabilitation, ask about it. The conversation takes 2 minutes and the benefit can be significant. If this information is giving you things to think about, I want you to hit the like button right now. It genuinely helps me reach more people who need to hear this. And if you are not yet subscribed, please subscribe now and hit that notification bell so you never miss these health conversations. The 5th area requiring honest discussion is emergency abdominal surgery. Now, this one is different from everything else we have discussed today because you do not choose emergency surgery. It happens when it happens. A perforated bowel, severe internal bleeding, a serious abdominal obstruction. These situations do not wait for a calm office conversation. But here is why it belongs in today's discussion. Understanding the risks in advance before the emergency happens genuinely changes how families make decisions in those terrifying moments when time is short and emotions are overwhelming. Emergency abdominal surgery in older adults carries some of the highest risk profiles in all of surgery. Not because surgeons are anything less than skilled and dedicated, but because an older body under sudden major trauma is managing multiple crises simultaneously. The liver, kidneys, heart, and lungs all come under stress at the same moment. The inflammatory response that a younger body contains and resolves within days can escalate in an older body into a systemic crisis involving multiple organ systems. The most effective thing you can do with this knowledge is twofold. First, do not ignore abdominal symptoms. Persistent, unexplained abdominal pain, significant changes in bowel habits, bloating that does not resolve, these symptoms in an adult over 60 deserve prompt medical evaluation. Catching problems while they are still manageable almost always means treating them before they become emergencies. That one habit of seeking attention early rather than waiting can genuinely change the entire clinical picture. Second, have an honest conversation with your family now, not in a hospital corridor at midnight when everyone is frightened and exhausted. Have it now calmly over a cup of tea. What are your wishes if emergency surgery becomes the only option? What quality of life matters most to you? What would you want your family to advocate for on your behalf if you cannot speak for yourself in that moment? These conversations are not morbid. They are one of the most genuinely loving and practical things you can do for the people who care about you. Pro tip number 3, ask your doctor to help you complete an advanced care directive or similar document that formally records your wishes regarding major medical interventions. This document gives your family and your medical team clear guidance during emergencies when you may not be able to communicate your preferences directly. Having it in place removes an enormous burden from the people who love you at the moments when that burden is hardest to carry. Now, let me give you a clear and practical action plan because information without action serves no one. Before any major surgery planned or recommended, there are 4 questions every adult over 60 should ask, and I want you to write these down. The first question is, what happens if I do not have this surgery right now? A confident and honest surgeon will give you a specific answer. If the answer is that nothing urgently changes in the next several months, you have time. Time to think carefully, time to get a second opinion, and time to optimize your health before proceeding. The second question is whether a less invasive alternative exists. Medicine has changed enormously in the past 15 years. Minimally invasive procedures, robotic-assisted surgery, catheter-based interventions, and endoscopic approaches now exist for many conditions that previously required open surgery. What was standard 10 years ago may no longer be the only or even the best option today. The third question is what recovery realistically looks like for someone with your specific age, your specific health conditions, and your specific living situation, not the average patient. You, your heart, your kidneys, your current medications, your support at home. The answer should be specific and honest, not a reassuring generality. The fourth question is the one most people never think to ask. What is the surgeon's personal complication rate for this specific procedure in patients over 70? Surgeons track their outcomes. They know their numbers. A confident and honest surgeon will answer this question directly. The response you receive, whatever it is, gives you genuinely valuable information. Let me also say something that I want you to hear clearly before we finish today. None of what we have discussed is an argument against surgery. Surgery is one of the most powerful and life-changing tools in all of medicine. The message today is about being an informed participant in your own care, about asking the questions that deserve to be asked, about knowing that alternatives often exist that are not always presented as the first option, about understanding that a surgical recommendation, however well-intentioned, is always the beginning of a conversation and never the end of one. Your age is not a reason to accept more risk than necessary. Your age is a reason to ask more questions, to take more time, and to demand more complete and honest answers. The best surgical outcomes I have ever seen came from patients who were fully informed, who asked hard questions, who understood their options completely, and who made their decisions with clear eyes and complete information. Let me summarize everything we covered today. Open heart surgery in older or frail patients carries risks that a less invasive catheter-based approach may avoid in appropriate cases. Aggressive spinal fusion for chronic back pain may carry high complication rates with outcomes that some research suggests are no better than non-surgical management for many older adults. Major cancer surgery in frail patients requires honest conversation about whether the operation genuinely delivers more good years of quality life. Elective joint replacement in patients with multiple serious conditions is safer when the body is properly optimized beforehand through prehabilitation. And emergency abdominal surgery is best prepared for not by avoiding it, but by catching problems early and having honest family conversations before any emergency occurs. 4 questions before any surgery. What happens without the operation? Is a less invasive alternative available? What does recovery specifically look like for you? What are the surgeon's personal outcomes for this procedure in patients your age? In my next video, I am going to discuss 5 natural approaches that some research suggests may support recovery and healing after surgery for older adults. You are not going to want to miss that one, so please make sure you are subscribed and have your notification bell turned on. If this video gave you something genuinely valuable today, please share it with someone you care about who is facing a surgical decision right now. That share could be one of the most meaningful things you do today. Remember, this video is for informational and educational purposes only. Always consult with your personal doctor before making any changes to your health. If you found this video helpful, don't forget to subscribe to the channel and hit the notification bell so you never miss a health tip. See you in the next video.